Hello guys, welcome back to the Medway platform. So today we are going to discuss the radiology questions that was asked in your recent FMGE exam. Right? I hope your exam went well. As far as radiology is concerned, okay, questions were very straightforward, one-liner, right? So I hope you guys must have got all these questions correct, right? So let us discuss these questions. So cotton wool appearance. So I have 9 questions with me. I don't have all the options. So if you can contribute, that would be great. So the first question is cotton wool appearance is seen in. So we all know cotton wool appearance is characteristic of Paget's disease, right? So let us discuss few important points about Paget's disease. It is common in people more than 40 years of age. So it is a bone remodeling disease. So what happens in this? There are phases of osteoclastic reaction, okay, in which you will see multiple lytic lesions, like in this skull you are going to get osteogenesis circumscripta, then you are going to get your blade of grass appearance, right? Then you have a mixed phase in which there is both osteoclastic as well as osteoblastic reaction, right? And you have an isolated osteoblastic phase. So in this disease you are going to get various phases, and depending upon the phase, okay, you can have various types of imaging appearances, right? Then yes, now talking about the important imaging signs in these patients with Paget's disease. So first we have already discussed the cotton wool appearance of the skull, right? So there will be osteoblastic reaction within the skull, and because of this multiple radiodensities can be seen. Also you will see that there will be widening of the diploic spaces and the skull will be thickened, right? Now talking about the osteoclastic reaction, a very important sign is your blade of grass sign. So what happens, there is osteoclastic reaction. You can see in this image there is resorption of the inner table of the skull, and this resorption of the inner table of the skull, it has an edge which we can see here. This is the edge, leading edge. So this leading edge of the osteoclastic reaction gives the blade of grass sign. Now second very important sign that we should know in Paget's disease is your osteogenesis circumscripta. So what happens, there are well defined radiolucent areas seen on the skull X-ray, right? So this is not a skull X-ray that I am showing you here, but this is a CT image of the head. And what we can see in this image, that this is the normal appearing bone, right? And here we can see this frontal bone, and it is appearing less dense as compared to the rest of the bone. Okay, the frontal bone, it is appearing less dense. This is because of the osteoclastic reaction that is happening here. So well defined radiolucent areas will be seen. This is known as osteogenesis circumscripta. Another very important appearance that you can get within the skull is your Tamo center sign. This is because of the basilar invagination, and you can also get platybasia in these patients. So the shape of the skull takes the shape of a hat, a Scottish hat, that is known as Tam O'Shanter, right? And on bone scintigraphy images or bone scan, you will see that there is increased uptake in the region of mandible, right? And the name of this sign is Lincoln sign, because of increased uptake in the mandible, right? Within the vertebra, guys, you can get ivory vertebra, again because of the osteoblastic reaction. Then you can get picture frame vertebra. So just remember these all the important named signs. So these will be helpful for you in your NEET-PG exam also, right? Now another few important appearances of the skull which I would like to discuss here, right? So another case is that of a patient more than 40 years of age, now presenting with bone pains. You get an X-ray of the skull done, and what do you see on the X-ray skull is that there are multiple well-defined radiolucent lesions within the skull, and these lesions are of various sizes. So this is the characteristic appearance, and this characteristic appearance, it is known as a raindrop appearance, raindrop skull. So guys, can you tell me in which case you are going to see this raindrop skull? So this is characteristically seen in patients with multiple myeloma, right? Multiple radiolucent lesions of variable sizes, right? Now coming on to the second image. So the second image also appears very similar to the first image, right? But here you will see that the radiolucent lesions, these are tiny radiolucent lesions. These are, you know, of uniform sizes, right? Tiny radiolucent lesions. The patient also has increased calcium levels within the blood, and the typical appearance of the skull is pepper pot skull. So this question is also very frequently asked in your exam in different ways. So these imaging features are seen in patients with hyperparathyroidism, right? So just be clear with these three important imaging appearances of the skull: cotton wool skull, Paget's disease, okay? Then you have raindrop skull, will be seen in multiple myeloma. Then your pepper pot skull or salt and pepper appearance will be seen in hyperparathyroidism, right? Then coming to your banana sign, again very basic question: banana sign and lemon sign, okay? All these signs, these are seen in patients with Arnold-Chiari malformation, right? So what happens in Arnold-Chiari malformation? There is a small posterior fossa, right? Because of the small posterior fossa, the shape of the cerebellum is like that of banana, right? Posterior fossa is small, your cerebellum is compressed, and it takes the shape of a banana. That is why this is known as banana sign. And in lemon sign, okay, the shape of the skull is that of a lemon because of the indentation of the frontal bones. The shape of the skull is that of a lemon, right? So important fruit signs. Another, if I talk about, you know, antenatal scan, frog eye scan is also very frequently asked. So we should all know frog eye sign is seen in patients with anencephaly. Then a question is asked: anencephaly is best diagnosed between 10 to 11 weeks, right? Is diagnosed as early as, right? So these were important points about these antenatal scan, okay? Lemon sign, banana sign seen in patients with Arnold-Chiari malformation. So patient who has been treated with tuberculosis in the past, right, now presented with hemoptysis, chest X-ray is shown. So I don't have the chest X-ray with me, but I have the few options. So let me discuss few options which were given to me by the students, right? So first one is aspergilloma, right? So this aspergilloma, guys, first of all I want to tell you that a patient who has been treated with tuberculosis in the past, Okay, so what are the possibilities that all these things can happen in this patient, right? Aspergilloma, yes. Fungal ball can form in patients with pre-existing cavities. Bronchiectasis can happen, okay, but it is not a feature of tuberculosis, okay. Mostly tuberculosis patients will heal with fibrotic changes. So again, bronchiectasis is again not a possibility. Pleural effusion is seen in patients with tuberculosis, right? But what happens, okay, this pleural effusion, it is not going to present with hemoptysis, right? Bronchogenic carcinoma, again TB in the past, okay. Bronchogenic carcinoma is very less related to the tuberculosis. It is not associated with tuberculosis in the past. So if I have to answer by not even looking at the options, I would go for aspergilloma, right? So let us see the important sign which is seen in patients with aspergilloma. So we have this, what is the name of the sign? It is Monod sign. So what you will see in this Monod sign, there will be a cavitary lesion, okay, which will be radiolucent, and this cavitary lesion, it will be filled with a fungal ball, right? Because of the infection of the pre-existing cavity, there is formation of fungal ball in these patients, and it gives the sign that which is known as Monod sign. So there will be a radiolucent crescentric shaped lucency around the fungal ball, right? So many of you guys can confuse it with air crescent sign. So let me tell you, air crescent sign and Monod sign, they have similar appearances, but these are not seen in same patients. Air crescent sign is seen in invasive aspergillosis, right? So if I am talking about invasive aspergillosis, another very important sign that you are going to see in invasive aspergillosis is halo sign. So what happens in halo sign? There will be a consolidation, and surrounding that consolidation there will be ground glass opacities due to the pulmonary hemorrhage. So this is characteristic of halo sign, right? Bronchiectasis will be seen in ABPA. So if I am talking about fungal infections, so these patients will have history of asthma, right? Their IgE levels will be raised, and on CT images you will see central bronchiectasis. So bronchiectasis has a characteristic sign which is known as signet ring appearance, and this appearance is due to the dilated bronchioles surrounded by a pulmonary artery known as signet ring sign, right? So just remember all these important signs. Monod sign seen in patients with aspergilloma. So remember, your final exam is still not over, that is your NEET-PG. Ultimately we aim to clear this NEET-PG exam, and ultimately we aim to clear the NEET-PG exam, right? And get a good college in the topmost colleges of India. So aspergilloma, Monod sign, air crescent sign will be seen in patients with invasive aspergillosis, right? In invasive aspergillosis, another important sign that you see is halo sign, okay. Bronchiectasis, you are going to get a signet ring sign, and in ABPA, guys, you are going to get a finger in glove appearance, okay. This central bronchiectasis is going to give a finger in glove appearance, right? And you should also know one more very important sign, which is known as reverse halo sign. So guys, this is seen in patients with cryptogenic organizing pneumonia and mucormycosis, right? Just remember this sign also, reverse halo sign, right? Now a 35-year-old male presented with general weakness and fatigue. His ultrasound abdomen showed bilateral renal calculi. Parathyroid levels were elevated. So obviously we are talking about hyperparathyroidism. Which of the following will be used in further evaluation? So guys, the most important thing, first we have to make a diagnosis that we are talking about hyperparathyroidism. Now we should know what is the most important cause of hyperparathyroidism. It is parathyroid adenoma. Now the question, I have already told you, parathyroid adenoma will be asked very frequently in your NEET-PG as well as FMGE exam. So do this topic very well in medicine as well as in radiology, right? So now they have asked investigation used to pick up parathyroid adenoma. It will be your technetium system scan, right? Now let us discuss few important points about parathyroid adenoma, right? Patients can have generalized weakness, okay, fatigue, osteoporosis, right? Renal calculi can result in okay, right? So these were the various options. So क्लिनिकल फीचर्स यू गाइस ऑल नो, ठीक है. अब हम रेडियोलॉजिकल पॉइंट ऑफ व्यू से देखते हैं. सो गाइस, इफ आई टॉक अबाउट USG, ओके, व्हाट आर यू गोइंग टू सी ऑन USG? सो वी शुड नो व्हाट इज द मोस्ट कॉमन लोकेशन ऑफ parathyroid adenoma. It is infrathyroid location, right? Another very important place where you can get parathyroid adenoma is mediastinum. So what you are going to see, you will see a hypoechoic lesion on the ultrasound images, and it will be separated by a echogenic rim of thyroid. That is your ultrasound, right? If you do a color Doppler scan, you can get a polar vessel sign. So basically this parathyroid adenoma, it is supplied by a branch from the inferior thyroid artery, and that branch can be seen on the color Doppler images, right? On the CT also, contrast enhanced CT, you are going to get this similar imaging appearances, right? And also just remember that in these patients we do a 4D CT scan. Okay, 4D means we are doing it in different phases, right? So we will do an arterial phase also, and we will do a delayed scan also. So what happens, this parathyroid adenoma shows increased enhancement in the arterial phase images, and it is going to show washout on the delayed scan. That is the characteristic feature of parathyroid adenoma. Now as far as system EB scan, okay, so on the system EB scan you will see that this thyroid this parathyroid adenoma, it is going to show increased uptake even on delayed scans. So that is the characteristic feature of parathyroid adenoma, right, on system EB scan. And these are the ultrasound images we have already discussed. On ultrasound it will appear as a hypoechoic lesion, and that hypoechoic lesion will be supplied by a vessel. So this is known as polar vessel sign. ठीक है, system EB scan, right? So nowadays a lot of questions are asked from the nuclear medicine. So just read all the important points. Okay, कौन सा स्कैन किसके लिए यूज़ करते हैं, लाइक योर टेक्नीशियम बोन स्कैन, राइट? So it is basically used for bone tumors. All bone forming lesions, they are going to show increased uptake on technetium bone scan. You should know the exception. Exception is multiple myeloma and thyroid mets. Okay, multiple myeloma is not going to show increased uptake on the technetium bone scan, right? Now talking about MIBG scan, remember this scan is used to pick up pheochromocytoma, and also neuroblastoma can be seen on the MIBG scan, right? And technetium DTP scan, it is used to check the renal function. So basically it is being excreted in the kidneys, so you have to see whether it is being normally excreted or not, right? Technetium DTP scan, renal function. Now talking about Codman's triangle, बहुत ही basic question है. We all know Codman's triangle is seen in patients with osteosarcoma, right? So guys, bone tumors, again very important topic, that is again repeatedly asked in your MCQs. ठीक है, तो bone tumors, if I just have to summarize for you guys, so always remember the main protocol, that is your ELTA protocol. Let me just summarize this ELTA protocol for you. So A stands for age of the tumor, okay, age of the patient. So if the age of the patient is less than 20 years, the tumors which are common are your Ewing's sarcoma, right? You have osteosarcoma, you have cyst. If the age is between 20 to 40 years, the tumors which are common are your enchondroma, right? You have giant cell tumor. If the age of the patient is more than 40 years, the tumors which are common are Mets, multiple myeloma, chondrosarcoma, right? Now then, location is very important. So if a tumor is located in the epiphysis, right? So the tumors common in the epiphysis, these are chondroblastoma and giant cell tumor. So chondroblastoma will be seen in patients more than 40 years, more than 20 years of age, right? And chondroblastoma will be seen in patients less than 20 years of age. ठीक है, ये आपको पता होना चाहिए. Then the tumors located in the diaphysis, they can be remembered with a simple mnemonic, that is your coffee. So coffee stands for cis, osteoid osteoma, fibrous dysplasia, Ewing's sarcoma, enchondroma, right? And rest of the tumors, these are common in the metaphyseal location. Then transition zone, okay, you need not remember transition zone, but let me just tell it to you. So transition zone is basically a wide zone of transition, okay, and a narrow zone of transition. Wide zone of transition is shown by malignant tumors. Narrow zone of transition is seen in benign lesions. And the last protocol about A is appearance, okay. So different tumors can have different appearances, like the question that was asked, okay. Basically your Codman's triangle, type of periosteal reaction. So basically on type of periosteal reaction, you can tell what type of bone tumor it is. So if a patient is having Codman's type of periosteal reaction, right, you are going to think of osteosarcoma. if there is an onion peel type of periosteal reaction, you are going to think of Ewing's sarcoma, right? Then you should also know if you have a solid periosteal reaction. Can anyone tell me solid periosteal reaction is seen in which patients? It is seen in patients with your osteoid osteoma. Right? Then you should know single lamellated periosteal reaction. This is seen in patients with osteomyelitis. Right? So here these are the images. In these images we can first see that this is the Codman's triangle, right? Periosteum is uplifted, and this uplifted periosteum, it ossifies, giving this appearance which is known as Codman's triangle, seen in malignant tumors. And another very important appearance that I forgot, that is your sun ray appearance. Okay, that is again very frequently asked. It is again seen in patients with osteosarcoma. One is Codman's triangle, and in this image we can see that there are multiple lamellated reaction giving an onion skin peel appearance. So this onion skin peel appearance, this is seen in patients with Ewing's sarcoma. Right? So type of appearance is very important. Okay, so few important another types we should know, that is your ring and arc shaped calcification. Ring and arc shaped calcification is seen in chondrosarcoma or chondroid tumors rather. Okay. Then if I talk about cloudy appearance, okay, type of matrix mineralization, it is shown by osteoid tumors. Right? So these are few important imaging appearances that we should know. Now a 25-year-old patient presented with low grade fever, okay, and cough. Chest x-ray is shown. So guys, can you tell me what chest x-ray was shown? So let me tell you about the two options. In miliary tuberculosis, what is you are going to see that on the chest x-ray you will see multiple tiny radiodensities, okay, nodules seen scattered in both lungs. Okay, so miliary tuberculosis, okay, you are going to see multiple tiny nodules. Okay, or miliary pattern, guys, we should also know it is also seen in fungal infections like histoplasmosis, blastomycosis. Then it is seen in patients with rheumatoid arthritis, right, in patients with metastasis. So you can also get these imaging appearance in these patients. Now talking about sarcoidosis, what you are going to see, you are going to see a chest x-ray with calcified hilar lymph nodes. So basically calcific radiodensities will be seen in the perihilar location. Okay, this is your trachea, right? So in sarcoidosis you will see calcific radiodensities in the perihilar location, right? So these were the two options that were given to me by the students. So calcific hilar lymph nodes are the characteristic feature. So you guys have to tell me what was given in the option, whether there were multiple tiny nodules scattered in both lungs or whether it was multiple calcific radiodensities in the perihilar location. Can anyone tell me in the comment section what was given in the option, whether it was calcific radiodensities or tiny nodules, right? So I've given you how are both looking on the X-ray. So most radiodensitive tissue, that is again asked very frequently, it is your testes is the most radiosensitive tissue, right? Again, one question was asked on the PET scan. You were, I think, asked to identify the investigation. What is the investigation shown? So it was most likely your PET image which was given. So basically what you are going to see on the PET scan, you will see a CT image, okay, CT image, and within that CT image you will see multiple color uptake, okay, color uptake or SUV uptake in the malignant lesions. Like here we can see red color uptake seen within the liver. So these are most likely your malignant liver lesions, right? So another question that was asked on the mechanism of PET scan, okay. So basically in this we are using fluorodeoxyglucose, right? So this fluorodeoxyglucose, right, it is metabolized to fluorodeoxyglucose 6-phosphate, right? Now this metabolism of this fluorodeoxyglucose will take place in the cancer cells, okay, because they are in a hypermetabolic state. They are going to metabolize fluorodeoxyglucose more, and this will result in production of this compound, that is fluorodeoxyglucose 6-phosphate, right? And this will result in production of positron, neutron, and this positron will combine with electron to result in and it will result in production of this increased uptake on the FTG PET scan, right? So you should know the basic mechanism of FTG PET scan. It will show increased uptake in the tumor cells, right? And it is used for staging of the tumor. It is used for looking up to find any metastasis, right? And what else? Normal increased uptake will be seen, you should also know, by the myocardium will show normal increase uptake, right? Then your intestinal wall may show increase uptake. Then it is excreted, okay, your UB, urinary bladder, may show increase uptake because of the excretion of this compound, right? Now last image that was given to me, that was your triple bubble sign. So we all know triple bubble sign is seen in patients with, and this is the image showing 3 bubbles, 1, 2 and 3 bubbles seen in patients with ileal atresia. Then you have the double bubble sign seen in patients with jejunal atresia, right? And you have the single bubble sign seen in patients with congenital hypertrophic pyloric stenosis and duodenal atresia. So congenital hypertrophic pyloric stenosis is another very important topic you should know, okay. So when do we diagnose a patient with CHPS? So the patient will present with non-bilious vomiting. You can also palpate an olive shaped mass in the right upper quadrant, right? And on USG you will see that the thickness of the pylorus will be more than 4 mm, and the length of pylorus that is involved, it will be more than 16 mm, right? So guys, this was all few important questions that was asked in the radiology. So if any other question that is asked or any other option that you would like us to discuss, you can always mention to us in the comment section. So till then guys, bye bye, take care, keep working hard and start your preparation for the next exam from the next day itself. ठीक है. So let me just before I end share an important story with you guys. So guys, जब मैं आपको बताता हूँ कि मेरा एग्ज़ाम था NEET-PG का, ठीक है. तो आई ऑलवेज़ वांटेड टू गो टू एम्स, ठीक है, बट अनफॉर्चुनेटली जा नहीं पाया. बट मेरा टारगेट मेरा हमेशा से यही था कि आई हैव टू गो टू एम्स. सो व्हाट हैपेंड, NEET-PG का एग्ज़ाम देने के बाद आते साथ ही फ्रॉम द नेक्स्ट डे इटसेल्फ आई स्टार्टेड प्रिपेयरिंग फॉर द नेक्स्ट एग्ज़ाम. ठीक है. सो एंड बिकॉज ऑफ दैट आई डिड वेल इन द NEET-PG एग्ज़ाम ऑल्सो. सेम वॉज माई स्ट्रेटजी. NEET-PG से पहले भी बहुत सारे एग्ज़ाम्स आए, जैसे CBT लोग देने जाते हैं, तो CBT देने के बाद लोग 3-4 दिन रेस्ट कर लेते हैं या 1 दिन रेस्ट कर लेते हैं, फिर अगले दिन से पढ़ाई शुरू करते हैं. तो मैंने अपनी प्रिपरेशन में गाइस ब्रेक नहीं ली. ठीक है ना. मैंने जिस दिन से प्रिपरेशन स्टार्ट करी और जिस दिन से एंड करी, ठीक है, उस दिन तक ब्रेक नहीं ली, अपना कंटिन्यूसली लगे रहे. ठीक है. चाहे पढ़ाई ज़्यादा हुई चाहे पढ़ाई कम हुई, रुके नहीं हम, है ना. तो इस चीज़ का आपको, ठीक है, डिफ़िकल्ट होता है, ठीक है, एग्ज़ाम के बाद पढ़ना. ठीक है. बट टुडे यू गाइस हैव स्टडीड एवरीथिंग सो वेल, ठीक है, इन द लास्ट कपल ऑफ डेज और मंथ्स, राइट. नाउ यू हैव द चांस टू बिल्ड अप अपॉन इट. ठीक है. जो भी आपके वीक पॉइंट्स है इसके ऊपर वर्क करो. कुछ सब्जेक्ट्स आपके ऑलरेडी स्ट्रॉन्ग हो गए, सम ऑफ द सब्जेक्ट्स माइट बी स्ट्रॉन्ग, राइट. नाउ यू जस्ट हैव टू रिवाइज दो सब्जेक्ट्स to maintain your level in those subjects and you have to work on weak subjects. FMGE का रिज़ल्ट तो आ ही जाएगा, ठीक है. देन आगे जो भी आपका NEET-PG एग्ज़ाम कुछ भी आएगा, ओके, you are going to do wonders in that also. And I will tell you what happens, why many students fail in various exams, very competitive exams. So over the years मैंने यही देखा लोगों को कि जैसे कुछ एग्ज़ाम्स अगर 6 monthly होते हैं, so why students are consistently failing in that. So what students do, they will give the exam, they will wait for one month, they will relax for 1 month, ठीक है, आराम करेंगे, फिर पढ़ना शुरू करेंगे, फिर धीरे धीरे पढ़ाई का मोमेंटम आएगा, फिर जब तक पढ़ाई का मोमेंटम आएगा तब तक एग्ज़ाम ही आ जाएगा, फिर ऐसे नेक्स्ट साइकिल चलता रहता है. So I will tell you that you guys now have the momentum of studying, okay, you guys have a good knowledge also, you just have to build up upon it. So just start preparing for your next exam. ठीक है. Bye bye, take care and all the best for your future endeavors. Thank you.